obstructive cardiomyopathy, HOCM. Question: a 16-year-old male athlete suddenly collapses during a basketball game. Bystanders report that he had no prior symptoms, but he briefly complained of chest pain and dizziness before collapsing. On physical examination, he has a systolic murmur at the left lower sternal border that increases with Valsalva and decreases with squatting. Which of the following is the most likely diagnosis? A. Aortic stenosis. B. Hypertrophic obstructive cardiomyopathy. C. Myocarditis. D. Pulmonary stenosis. Hypertrophic obstructive cardiomyopathy, HOCM. Explanation: HOCM is an autosomal dominant genetic disorder characterized by asymmetric hypertrophy of the interventricular septum, leading to left ventricular outflow tract, LV out obstruction. The hypertrophy leads to systolic anterior motion, SAM, of the mitral valve, which worsens obstruction and can cause sudden cardiac death in young athletes. Key features: young athlete with sudden collapse or syncope, harsh systolic ejection murmur, left lower sternal border. Murmur increases with Valsalva and standing, preload. Murmur decreases with squatting and hand grip, afterload, preload. Echo shows asymmetric septal hypertrophy and LV out obstruction. ECG shows LVH, dagger-like Q waves. Why not the other answers? Aortic stenosis. Murmur is best heard at the right upper sternal border, not left. Murmur increases with squatting, opposite of HOCM. Bicuspid aortic valve in younger patients, calcific degeneration in elderly. C. Myocarditis, usually preceded by viral illness, e.g. Coxsackie virus. No dynamic murmur changes with Valsalva or squatting. Presents with heart failure symptoms, not just sudden collapse. D. Pulmonary stenosis. Murmur best heard at the left upper sternal border. Widely split S2, not seen in HOCM, not typically associated with sudden cardiac death. Management of HOCM: first-line treatment, beta blockers, HR to prolong diastolic filling. Second line, non-dihydropyridine CCBs, verapamil if BBs not tolerated. Avoid diuretics, vasodilators, and high-intensity sports. High-risk patients, implantable cardioverter defibrillator, ICD, to prevent sudden cardiac death. Surgical options: septal myectomy or alcohol septal ablation in severe cases. Bonus clinical tip: if a young athlete collapses suddenly, always suspect Hocm until proven otherwise. Would you like